Good evening, ladies and gentlemen. At the outset, I would like to thank Dr. Kamal Sharma sir, Chairman Scientific Committee, and all the other organizing committee members for giving me this opportunity to present a case of Tricvalve in this update, Cardiocon update, recent update session. So in our day-to-day practice, we tend to underestimate and undertreat tricuspid regurgitation, mainly because the limited therapeutic options on one hand, and it carries very high morbidity and mortality, and surgical mortality is very high on the other hand. So same thing happened to my case. So my case is a 53-year-old gentleman, LIC officer, who had a road traffic accident with head injury and polytrauma 20 years back. So he underwent neurosurgery and subsequent orthopedic surgeries in a peripheral center. So where he developed sepsis during the course of hospitalization, and it caused infective endocarditis of tricuspid valve. So then for the management of infective endocarditis, he was shifted to famous teaching institute in Hyderabad, Nizam's Institute of Medical Sciences, and where he was successfully treated for his infective endocarditis with long-term antibiotic therapy. But unfortunately, he developed he left with mild tricuspid regurgitation at that time. So then the doctors told him, reassured him that nothing going to happen with mild TR. So they reassured him and discharged him. So he also forgot about his condition, and he carried on later. But subsequently, for the last 5 years, again, he developed cardiac symptoms as well as pedal edema, gross abdominal distension. So he consulted local physicians and found to have a very severe tricuspid regurgitation with early stage of cardiac cirrhosis. So from then, his natural course was complicated by recurrent hospitalizations with congestive cardiac failure, abdominal distension with episodes of spontaneous bacterial peritonitis. So he visited many hospitals for the treatment of TR, but nobody offered him any therapy, mainly because of his comorbid conditions. And he is also a known case of hypothyroidism, rheumatoid arthritis, and cholelithiasis. He had left lower limb DVT in 2013, managed conservatively, and he underwent umbilical hernioplasty in 2017 at our center by senior most surgical gastroenterologist. These are the MAS before and after the umbilical hernioplasty. In last year, during the COVID wave, he developed COVID pneumonia. Everybody in the family thought with so many comorbid conditions, he'll not do well. But luckily, he recovered with home isolation only. But in the month of July 2021, he admitted again in our center with severe pain abdomen under the same surgical gastroenterologist who treated him earlier. Again, he was diagnosed to have spontaneous bacterial peritonitis, and at that time they did a paracentesis and they could aspirate a purulent aspirate. Cultures were sent and Pseudomonas was grown, and he was started on higher antibiotics. Just like a routine consultation, because he's having severe tricuspid valve regurgitation, they gave referral to cardiology, and nothing they expected much from us except managing the edema part. But on examination, he had functional class 3 symptoms, gross pedal edema, huge scrotal swelling with gross ascites. These are the images with gross ascites and pedal edema. On examination, JVP was elevated and bounding. ECG showed atrial fibrillation with controlled ventricular rate. Right bundle branch pattern was there. 2D echo, you can see here, grossly dilated ARIA-RV with severe low pressure TR with taps of 20 millimeters. And you can see the myxomatous mitral valve with some mild eccentric TR with paired biventricular functions. Coming to the labs, LFTs were deranged. He had hypoalbuminemia. RFT was normal. and total leukocyte count was elevated. So, when I discussed with our heart team colleagues, so surgeons turned down this case for any sort of repair because of so many comorbids and the risk of high mortality. So we have very limited interventional options. So these are the options of transcatheter tricuspid valve landscape. So we have a direct suture annuloplasty, direct ring annuloplasty, coaptation enhancements, and valve replacements. These are all various devices under development at various stages of development. But definitely Tricvalve is available now for the therapy. So we narrowed down our possibilities to Tricvalve. This is the Tricvalve system. It comes as a bicaval valves, two valves. One we have to implant in SVC, this valve, and the other one is in IVC. So these are the nitinol frames with bovine valves attached to it. So to prevent the caval reflux. So for any structural intervention, CT angiogram is a must. So CT planning is necessary. It decreases the possibilities of paravalvular leak as well as migration of the valves. Proper sizing is very essential. So we have done the sizing, and so for us it came like SVC 29 millimeters valve and IVC 41 millimeters valve. And this is the 3D imprinting of the CT. We can see grossly dilated RA and RV with rotation to the left. So when we were planning all these things, but his intra-abdominal sepsis worsened and he started having pus inside. So initially that was managed by an interventional radiology colleague with pigtail drainage conservatively, almost close to 15 to 20 times he drained pus, but still it was coming. So then they suspected bowel perforation. CT abdomen was done. They suspected appendicular perforation on CT abdomen. Then subsequently, surgical gastroenterologists went ahead and they did diagnostic laparoscopy, and peritoneal wash was given with adhesiolysis was done. And subsequently, he developed lower respiratory tract infections, recurrent pleural effusions, again drained by the interventional radiologist under ultrasound guidance. And one day he had one episode of code blue in the room, but that was successfully resuscitated by our critical care team. So once the drain stopped, cultures became negative. We thought that is the right time to implant the valves. And so at that time, valves were not available in India. So we ordered the valves and we were preparing for implantation. But unfortunately, he developed a septic shock. So he required multiple inotropes, and he was intubated and kept on ventilator. And subsequently, he developed AKI. He was on CRRT. So during that CRRT and ICU stage, he developed one more episode of cardiac arrest. So at that time, everybody in the team thought he will not make it. So everybody lost hope. But after 1 week of CRRT, slowly his urine output started coming, and his creatinine also started decreasing. So then at that time, our main dilemma was whether to go ahead and implant the valves or to wait till everything becomes normal. So then we counseled the family. In the family meeting, the family members told that anyway, we have paid for the valve and valves are available. Why don't you go ahead and put the valves? Let's see the effect of the valves. So with that encouragement, and we took a chance. And so on the day of implantation, he was on CRRT with multiple inotropes and on ventilator. So we took him for the procedure. Then this is the procedure. For right groin, mainly we use for the device delivery, and the left groin we use for the landmarks, like one catheter in the right pulmonary artery for the implantation of the SVC valve, and the other second valve is for the for the placing of the looped wire in the RA to identify the SVC RA junction as well as RA junctions. So these are the steps. So finally, after placing the landmarks, we have pushed the SVC transcatheter heart valves 29 mm into the SVC, and this has to be deployed above the RPA catheter. The belly part, which is a protruding belly part, we have to keep it above the RPA catheter. So we have deployed that, and this is the final full deployment of the SVC valve. Again, after doing the hepatic vein angiogram, so we have identified the hepatic vein origin, and then we have taken the IVC valve again, and we have deployed above the hepatic vein. And this is the final angiogram after the putting both the bicable valves. So we can see there was no reflux, valvular or paravalvular. So this is the final check angiogram, and this is the intraoperative TEA. So here you can see the IVC valve opening, closing nicely, and here the SVC valve again opening and closing nicely. And the groin is pre-closed, so no necessary for surgical cut down or surgical closure. And this is the final result of after the putting both the valves in place. This is the SVC valve with the protruding belly between, and this is the IVC valve. And on third day, we extubated him, and we mobilized him in ICU, and subsequent recovery was very amazing, and so he improved. He was extubated, and CRRT was stopped, and his abdomen girth was decreased so drastically. Overall weight decreased, and he was shifted to room, and he came for follow-ups, 3 follow-ups till now. So we have done 3 months follow-up. This is the follow-up echo of 3 months. So we can see the slightly reduction in size of RV, RA. PR is there still, but slowly, gradually, I hope it will come down. So take-home message here is Tricvalve is the latest in the horizons of tricuspid therapy. It helps in reducing symptoms and recurrent hospitalization in patients with severe tricuspid regurgitation with caval reflux. And the caval valve implantation is technically easy, simple. It's like putting the filters, IVC filters, similar to that. And the good part is now this therapy is available in India. So when I implanted, I imported it from Germany, but now it's available in India, so we can order. And these valves are pre-mounted valves. There is nothing like much preparation required during the procedure. You can straight away go ahead and after identifying the landmarks, you can deploy the valve. Thank you very much for your patient listening.